Today you will learn there's two novel prediction tools that we can use in those febrile infants aged 61 to 90 days. The first one, you are low risk if you have a negative urinalysis and your highest temperatures are less than or equal to 38.9 degrees Celsius. The second rule involves blood. They identified that you are low risk if your procalcitonin is less than 0.24 and your ANC is less than 10,710 cells. But wait, don't apply it yet. Listen more, read the article, let's talk about it.
Welcome to EM Pulse, bringing research and expert opinion to the bedside.
We're your hosts, Julia Magana
and Sarah Medeiros.
Welcome back to EM Pulse. We have long struggled with what to do with a febrile infant. Fortunately, PECARN and the AAP have given us some tools to use when we have a febrile infant aged 0 to 60 days. But are they magically low risk for serious or invasive bacterial illnesses when they turn 61 days old? What's going on at day 61? The good news is that PECARN is helping us figure it out. Our colleagues published in August 2025 in Pediatrics. The title of that article is Prediction Rule to Identify Febrile Infants 61 to 90 Days at Low Risk for Invasive Bacterial Infections. To walk us through this murky swamp, we have my old boss and Executive Vice President, Chief Academic Officer, and Chair of Pediatrics of Children's National Hospital in D.C., Dr. Nate Kuppermann, here with us today. Welcome, Nate.
Hey, great to be back, Julia. Great to see you in Orlando and Paul.
We also have Dr. Paul Aronson, Professor of Pediatrics and Emergency Medicine at Yale School of Medicine. Welcome to EM Pulse, Paul.
Yeah, thanks so much for having me. It's a pleasure.
Okay, Nate, you and I have talked on EM Pulse several times about the work PECARN has done on febrile infants 0 to 60 days. So we're not going to go into that. We might dance around it a little bit. But I will put a link into the podcast show notes on those podcasts so you can listen to them. But as a quick reminder, PECARN prospectively derived a clinical decision tool that can be found on MD Calc. It identifies which febrile babies are at low risk for serious bacterial illnesses. If you have a normal urinalysis, absolute neutrophil count, or ANC, less than 4,000, and a procalcitonin less than or equal to 0.5. If you meet all three of these criteria, you're classified as low risk for serious bacterial illness and may be considered for less invasive management, such as avoiding the lumbar puncture, empiric antibiotics, and hospitalization, just depending on your clinical context. The AAP then integrated the PECARN rule, but has some nuances, including using a CRP and options without a procalcitonin, since not all hospitals had access to a procal. Okay, remind us all, what is the definition of this serious bacterial illness, and what's the definition between invasive bacterial illness?
These are sort of terms that researchers and clinicians have put around infections to make life a little easier, although they actually really haven't. But serious bacterial infection is a definition for this constellation of three infections that you not uncommonly see in young febrile infants: urinary tract infection, bacteremia, and bacterial meningitis. Now, of those three, two are more serious, and those are called the invasive bacterial infections, which is bacteremia and bacterial meningitis. And I need to add in an editorial fashion that even that constellation is probably a bit misleading, because bacteremia is not the same as bacterial meningitis. So in the modern era, we probably should be talking about all three of those infections in a separate fashion, that is UTI, bacteremia, bacterial meningitis. But for ease of discussion and for use in research, we've typically classified them into those two categories: serious bacterial infection or invasive bacterial infection.
Okay, and getting back to that magical 61-day marker, why do all of these studies stop at 61 days?
Sure, it's a really good question. We wish life was just really simple, that there was cutoffs that were perfect, and we could divide things so really into nice little packages. And we have pretended to do so in this area of study. Again, Paul will go into details in the current study, but we have typically broken febrile infants up into age categories of 0 to 1 month or 0 to 28 days. Some people say 0 to 22 days, and then the second month of life, or 29 to 60 days, and then 61 days to 90 days, because somehow we would love to believe that there's these perfect differentiators that make these groups different. The sad news I have to bring to your listeners today is life is not that simple, and it really is a continuum. But in general, you can say that the older you get in that spectrum, the decrease in your risk of these infections in general, although it's not a perfect, linear association. So the first 2 months of life are higher risk. So all of these prediction rules, not all, but most of the prediction rules have focused in the first 2 months of life. I will say we have our good colleagues in Spain who did the step-by-step rule. And in that rule, it went all the way to 90 days. And, I have to give them a shout out because one of our friends and colleagues, Santi Montegui, was I think he was the senior author of that paper. He's always said, well, the third month of life, the risk of bacteremia doesn't go away. It's not that dissimilar from the second month of life. And he is totally right about that. So we have sort of put a blinder historically under that third month of life, thinking things kind of disappear, but they don't.
Paul, another thing that comes up at the 60-day mark is a lot of kids have access to vaccines at that point. Is that a part of the thought process as to why 60 days? I know I was knocking on my pediatrician's door at 6 weeks with my babies.
Yeah. I would say that the main vaccine at 2 months or 60 days that plays in is the pneumococcal vaccine. And so conceivably, over 2 months, you start to see less of that infection, though you still see E. coli. It's a major urinary pathogen, and a lot of bacteremia in this older age group is bacteremic UTIs. You still see a little trickling of group B streptococcus. I would say it's unclear how much the pneumococcal vaccine affects that 2 to 3 month age group because we do still see pneumococcal there. So I would say vaccines, I think, play in a part theoretically in our mind, though in actual practice, to Nate's point, the risk or the prevalence of invasive bacterial infection, specifically bacteremia, is still non-negligible. It's not that far off from that 29 to 60 day age group. So I think vaccines play a little bit of a role, but still have a reasonably high enough prevalence of bacteremia for us to need a prediction rule for that age group.
That makes sense.
And I'm just going to tag one thing on to what Paul has said very astutely, is that even though you get the conjugate pneumococcal vaccine at between 6 and 8 weeks, depends on when you get into your physician's office, it takes several weeks for that to have an effect, right? So we're talking about months 2 to 3 where you might have gotten the vaccine. It doesn't mean the vaccine is giving you the full protection. In fact, we know it's not giving you full protection in that third month.
So, Paul, I know from my own hospital, and okay, I'm going to let you in on a little secret for my own practice. I may vary in how I treat the febrile infant who's older than 60 days. Clearly, we still need some guidance in that 61 to 90 days. How did you guys aim to fill that gap? Talk to us a little bit about the study methods here.
Yeah, I think you hit the most important point where there's significant variation in this 61 to 90 day age group, both inter-provider, so between providers of the same institution and across institution. And the AAP guideline that Nate and you referenced before, which was published in 2021, only includes recommendations up to 60 days of age because there's significantly less evidence to guide management in this older age group. So we aim to fill this evidence gap by deriving and internally validating a clinical prediction rule to identify febrile infants in that 61 to 90 day age group who are at low versus non-negligible risk of specifically invasive bacterial infection. So we sort of took UTIs out of it, since most UTIs will be identified by an abnormal urinalysis, and focused instead on invasive bacterial infections. So briefly, we used the PECARN registry, which was started in January of 2012. At the time of our study, it includes 17 EDs at 10 health systems with continuous data from registry inception through April in 2024 is when we stopped our study. Those sites joined the registry sort of at different time points, but essentially 17 EDs at 10 health systems were included. And so we included just a hair under 5,000 infants in that 61 to 90 day age group who had temperatures of 38 degrees Celsius in the ED or at home or an outpatient clinic. They had to be previously healthy, not critically ill, and really importantly, had to have both urinalyses or urine dipsticks and blood cultures obtained to be included. We then did a secondary analysis where we limited our cohort to the 1,200 or so infants who also had a procalcitonin and absolute neutrophil count obtained, as Nate referenced before. Those are components of the PECARN prediction rule in infants 60 days and below. And then we used CART analysis based on recursive partitioning to derive the rules with tenfold internal cross-validation.
I bet it'd be interesting with inside of that data set, Paul, to just see the variability between these children's hospitals. That's an interesting question in and of itself of this group that you've collected.
Yes, for sure. And we would expect there's significant variation.
Okay, why stop at 61 to 90 days? Why stop at 90 days?
Yeah, so I think a couple of reasons. So one is, to Nate's point before, you really probably start to have some protection from immunization the older you get. I think 90 days and above, you really should start having that 2-month vaccine effect. Also, probably you start having a lower prevalence of invasive bacterial infection, though it's been documented in a few studies that the prevalence is definitely lower as you get above that 3-month age group. And then third, the Yale observation scale, which was a scale sort of that was developed now like 4 decades ago, to when you just observe a young child and can determine well appearance versus ill appearance. Nate's PECARN and other groups have documented, well studied in the 60 days and below age group, it doesn't perform as well, meaning that a well-appearing child still has a very significant risk of invasive bacterial infection. But there has been studies, again, now several decades old, but as you get older, that sort of 3 months to 36-month age group, that sort of well appearance starts to better predict the lack of having an invasive bacterial infection. So I think we can better assess social cues in those infants as they get older. So I think that's why we decided to cut off at the 90-day. It's not that the risk becomes zero, but it does become lower after you get really above 3 months of age.
You're not just saying that because you're a Yale guy, are you?
Yeah, I was just going to say, you know what? I just needed to chime in something. First of all, Paul, I knew you were going to sneak in the Yale thing, being a Yale guy. But I was just going to add one thing. It's interesting to the general question of why stop at 90. Totally agree with Paul. Then there's good studies that looking at the effect of 1, 2 versus 3 of the conjugate pneumococcal vaccines, and more than 30 days out from the first conjugate vaccine, you start really having an effect. So to Paul's point, you definitely see decreased bacteremia. But the other thing to note is that the rule that Paul and I developed in this study that we're talking about, if you look at the main rule, it's still pretty good all the way up to 6 months, I would say, because for the febrile infant in the first 6 months of life, I do pay attention to the temperature, how high it is, and I get urine on them all. And that really is the main predictors of the main rule that Paul's describing. So
I just have to make one just disclaimer before we move on about the Yale observation scale. I was born at Yale, and so around the time it was developed, I was a child here. So it's possible I was a subject in that study. So I just have to say the conflict of interest.
Yeah,
just there.
geez, we don't usually have those kind of disclosures here. Okay. So what did you find, Paul? How often did you find invasive bacterial illnesses in this 5,000 patient set? And what were the most common invasive bacterial illnesses?
Yeah, so similar to what PECARN has found in the age 60 days and below group, we found that 2% of febrile infants had invasive bacterial infections, the vast majority of which were bacteremia. Only 0.1% had bacterial meningitis. So bacterial meningitis is really uncommon in this sort of 61 to 90-day age group. One important caveat, though, is our study inclusion criteria required that infants had to have urinalyses or urine dipsticks obtained, since urinalysis is a strong predictor of invasive bacterial infection in other studies, such as the PECARN rule. And we require blood culture to be obtained because that's how you test for the outcome of interest in invasive bacterial infection. And that was actually only about 30% of all the febrile infants evaluated at PECARN registry EDs in that 61 to 90-day age group during the study period. So our IBI prevalence of 2% is consistent with infants who are younger, but if you include all febrile infants in this age group, it would likely be a little bit lower than that. It's still non-negligible, still an important number, but definitely probably lower than 2%.
Did you track them like beyond the 90-day window to see if those that didn't have a blood culture drawn at the first site maybe bounced back with a sicker presentation?
Yeah, so we felt that 7 days was a reasonable time frame for the same illness episode. So we tracked them for 7 days, and there's very, very, very few that came back. But we did track all the infants in the study for 7 days after their initial visit.
I was going to add one quick thing to that, is that although the frequency of bacteremia, as Paul said, really similar to what we found in the second month of life. If you look at the pathogens that cause the bacteremia, really interesting. There's, I think, 4 patients with pneumococcal bacteremia, which you really very, very uncommonly see in the first 2 months of life. It's sort of the natural history that we would expect, a diminution, a decrease in those bacteremias that we traditionally see in the first 2 months of life, and suddenly the appearance of pneumococcal bacteremia.
What were the other invasive bacterial illnesses? Like, what was the profile there?
So it was several patients with E. coli or other gram negatives. And then group B strep was still a pathogen. And as Nate said, strep pneumococcal was a significant pathogen as well. And we'll get to the infants from our first rule who were misclassified as low risk. And there it actually really pops that, almost a third of those infants actually were from strep pneumococcal who were low risk per our rule. So those are the main pathogens.
Yeah, and I'm going to clarify one thing I said, Julie. I'm glad, Paul, you pointed that out. When I said that 4 patients had bacteremia, those were 4 of the 14 patients that were missed by the main rule. But to Paul's point, it was about a third overall that had pneumococcal bacteremia.
Okay, so we're talking about 2 rules. Why 2 rules? Why not just one?
First, I think that the larger cohort, which was our primary analysis, we could not study procalcitonin, since procalcitonin still is very used across sites, especially over the time period of our study from 2012 to 2024. When you actually look at it, sites have increased use of procalcitonin over time. A lot of that probably has to do with the highly sensitive and specific PECARN rule for febrile infants 60 days and below that's now trickled into this older age group. But if we required procalcitonin for the primary analysis, we would have had a lot of missing data. So we derived a rule without procalcitonin as a primary analysis. The benefit of that rule actually doesn't include blood testing. So it's conceivably applicable to community EDs, possibly even primary care offices. Obviously, it would have to be studied in that environment. And then we did a sub-analysis that required procalcitonin and absolute neutrophil count to be sent. And then that subsequently derived a rule there, which actually had even improved test characteristics, which is also consistent with the PECARN rule for febrile infants in the first 60 days of life, where if you have procalcitonin available, remains highly sensitive, but it really increases specificity, so fewer false positives. And so we think the procalcitonin rule has great value there, but we were just more limited in the number of infants who had procalcitonin available.
Okay, so walk us through this first rule.
So in our primary analysis of almost 5,000 infants using CART, we found that an infant was classified as low risk if their maximal qualifying temperature, meaning temperature at home or the first temperature recorded in the emergency department, was less than or equal to 38.9 degrees Celsius, and they had a urinalysis that was negative. So those are the 2 predictors that were found. And if you had neither of those, so lower temperature, less than or equal to 38.9 degrees Celsius, and then negative urinalysis, you were classified as low risk.
And how precise is this rule?
I would say similar to really every prediction rule out there, and not surprisingly, is the negative predictive value is very high. It was 99.5%. And that just more speaks to the fact that the vast majority of febrile infants in this age group that we evaluate don't have an invasive bacterial infection. The sensitivity, though, so of infants who had an invasive bacterial infection, sensitivity was 86%, meaning that 14 out of 100 infants with invasive bacterial infection would have been misclassified as low risk by the rule. That sensitivity is a little bit lower than, for example, the PECARN rule for febrile infants 60 days and below. Specificity was, reasonably high, so just a hair under 60%. But the biggest sort of caveat to this non-procalcitonin-based rule is the sensitivity is a little bit lower. So 14 infants would have been misclassified who actually had an invasive bacterial infection.
The vast majority of these 14, basically all of them, except for one, and I'm going to let Paul talk about that one, had bacteremia rather than bacterial meningitis. And the reassuring thing for me, even though you're missing 14, first of all, if in the screening, the 2 factors, if you have a high temperature above 38.9, that would prompt you to get LAMs, presumably. Okay. And if you have a positive UA, that would prompt you to get antibiotics. And the vast majority, 13 of the 14 that were missed, have bacteremia. And, oral antibiotics are probably pretty good for bacteremia. We've never done the study to compare oral versus IV in this age range, right, for bacteremia. I'm not talking about bacterial meningitis, just bacteremia. But the patients that we miss, a lot of them would get antibiotics because they have a positive UA. Not all, but a lot of them. Paul, I'll let you talk about the other spicy one.
Yeah, let's hear this one infamous baby.
Yeah. And I think to add on to what Nate said, I think the important thing is, so we use registry data. We excluded infants who were critically ill by specific definition. We could not assess clinical appearance. And I think that's also a question of our 30% of the overall population that we studied who had blood cultures and urine testing done. Probably a percentage of those were ill appearing. And that's why blood testing was done. So there was one febrile infant who was a 77-day-old who had group B strep, bacteremia, and meningitis, who had a temperature below that threshold, 38.9, and a negative urinalysis, but had group B strep meningitis. Interestingly, that infant was admitted and had a lumbar puncture on their initial visit, which makes us think that infant probably was ill appearing. We don't know that for sure, but just guessing, because given that lumbar punctures are not very common in this age group, as opposed to febrile infants who are younger, our sort of inclination is this infant may have been ill appearing or something prompted the clinician to do that workup. But technically, one infant would have been misclassified just looking at urinalysis and temperature as low risk. But our suspicion is that the infant may have had a clinical appearance that would have prompted more aggressive or invasive testing. And that really speaks to the need to prospectively evaluate these rules, because then you can better capture clinical appearance.
Okay, walk us through the second rule.
So when we limited the cohort to febrile infants who had both a procalcitonin and an ANC obtained, we had 1,207 of those infants. And what CART found is that the low-risk predictors were procalcitonin less than or equal to 0.24, and then ANC less than or equal to 10,710. So slightly different cut points, same predictors, but slightly different cut points in the PECARN rule for febrile infants in the first 60 days of life. The sensitivity of that rule was 100% on derivation with a specificity of 65.8%. So pretty similarly high specificity to the PECARN rule in those younger febrile infants with a very high sensitivity. Again, I think showing that procalcitonin, besides being highly sensitive, just really increases your specificity, with the benefit sort of downstream with fewer false positives, conceivably fewer infants getting antibiotics, fewer infants getting lumbar punctures and hospitalization. So that was our second rule.
And when you looked at this second rule, do you have to have those first things, the urine and the temperature as an entry point, and then you get the ANC and the procal? Or how does that play into this?
So we discussed this, and I think that in this age group, certainly the prevalence of, and this has been shown in other studies, prevalence of UTI it's higher. It's higher than invasive bacterial infection. And so most providers, not all, but many providers would get a urinalysis sort of as an initial step in many of these infants, regardless of a rule. However, when you have procalcitonin available, clearly it shows that urinalysis itself is not independently predictive of bacteremia. And so our thoughts are that conceivably, one option, we have to study this, would be if you were high risk, or better phrased as non-low risk in the first rule. So your temperature was high, your urinalysis was positive, then you could think about applying this sort of second rule. Or just if a clinician was inclined to obtain blood testing based on clinical appearance, based on higher temperature, the other clinical factors that probably right now influence clinicians to obtain blood testing, that's where we feel this rule is applicable. The important thing that we wrote this in the paper is we are not aiming to increase blood testing in this age group, but rather, given that around a third of these infants are getting urine and blood testing, for clinicians to be able to apply evidence when they actually obtain blood testing, so they have an evidence-based strategy when they do that. So I think that, yes, I think if probably higher temperature, clinical appearance, plus minus positive urinalysis with other factors may prompt you then to use this second rule, which has improved test characteristics compared to the first rule.
Yeah, I'll just add, and Julia, it's a super important question, because Paul and I and most people that do research in this area would uniformly say, hey, in this age range, you need to get a urine. You test the most common, easily identifiable bacterial infection in infancy. We don't want to miss it. So even though that second rule just is the procal and the ANC, we would certainly say you got to get urine on these patients, because remember that the outcome of interest is IBI, right, which is bacterial meningitis. Paul, I don't remember how many patients with UTI alone would we miss if we just got blood and not urine. So something to keep in mind. And one other thing I'm just going to add, and this is important because Paul and I have both studied this in one of our PECARN ancillary studies. In our cumulative patients that we enrolled over more than a decade, we had 697 infants in the second month of life with a positive urinalysis, okay? By definition, none of them were critically ill because that was prospective study, that was exclusion from the PECARN enrollment. Of those 697 with a positive urinalysis, not one of them had bacterial meningitis. Now, there's other studies that show that bacterial meningitis sometimes can still appear, but at least in that cohort in PECARNs, 0 out of 697. So like always, we're kind of using the cumulative evidence. And that again is in the second month of life. So you'd think that the risk would even be less in the third month of life, is that given a positive urinalysis, having bacterial meningitis. So I guess my point is that we always want people to get urine, but if their urinalysis is positive in the second or third month of life, the risk of bacterial meningitis is extremely, extremely low. So just something for the listeners to keep in mind.
Okay, so I mean, the simple-minded version of my clinical practice is like, okay, why is the ANC and ProCal not the same? Like, do I have to remember this odd number? And Nate, you and I have talked about this is what happens when you put it into the calculator and it spits it out. It's not always clean and simple. Can I use those same cutoff values that you predicted for the babies, the little ones?
I have spent so many years studying the ANC. It started with older infants, before okay, man, I've been around since before the conjugate pneumococcal vaccine. And we have these prediction rules for bacteremia in the 3 to 24 month old. And everything was always historically based on the white count, this and that. And as Julia, you pointed out, the prediction rules that Paul has been involved with and I've been involved with, we use statistical methods to identify the important variables. And the truth is when you put in the ANC and the white count, whatever, the white count falls out. It's not as important as the ANC. So we know ANC is important, okay? But then you have to know the pathogen. And I'll tell you, the most complicated publication I've ever written in my lifetime was a 1999 article in Pediatric Clinics of North America on occult bacteremia. Oh my God. There was hundreds and hundreds of references. It took me like a year to write. It was so painful. And then actually the editor wanted me to make all these changes. And I said, I am so sorry. I am not going to make any changes. I've worked too hard on this already. But in that article, it highlights how the ANC is different by the pathogen. So if you have occult meningococcal bacteremia, your ANCs in well-appearing infants, they're typically low. If you have occult salmonella bacteremia, it's even lower. But in occult pneumococcal bacteremia, that gives you high white counts and high ANCs. That's different than E. coli, which is the pathogen that we most commonly see in the first 2 months of life. So the point is that in this third month of life, we start seeing pneumococcus, right? A third of the patients with IBI, with invasive bacterial disease, have pneumococcus. They have high white counts and high ANCs. So by definition, that ANC threshold was going to be different than in the first 2 months of life where you don't see pneumococcus. And the second point I'll make, and Paul already alluded to this, remember in that secondary analysis, including blood, that was only 30% of the patients, something like that had ANC and ProCal. So it's a very selected group of patients. It's not like in PECARN when we enroll everybody. For the blood testing for ANC and ProCal, it's only 30%. So there's likely something different about those patients. They might look more ill. They might have higher temperatures. They might have other factors that would change the cutoffs of the predictors. So the bottom line, to summarize very briefly, is to say this was a selected group that got blood testing, only 30%, and pneumococcus is now a pathogen. And both of those reasons would drive different thresholds of ANC and ProCal.
We actually did look at the PECARN cutoffs of the ProCal of 0.5 and the ANC of 4,000 that you mentioned at the beginning, Julia. And we applied that to the same cohort with PCT and ANC obtained. And the test characteristics were still 100% sensitivity. Specificity was slightly lower, more around 50%. Again, it wasn't derived in this age group. But that being said, we also recognize the challenges of, that now they turn 61 days, and now I have to slightly adjust my cutoffs. The PECARN rule for febrile infants 60 days and below still works pretty well, at least in our initial study, in that 61 to 90-day age group, with perhaps cutoffs that are just more, at this point, more ingrained in people's minds.
Yeah, it's a really good point, Paul. This is a nuance that keep Paul and I awake, and folks that do this for a living, is that even though we always want a high sensitivity, right? Because we do not want to miss patients with serious illness. That's what sensitivity is, right? It's given the outcome of interest, given the bad disease, how good is your test at picking it up? So we love the fact that the blood test picks them all up. But we also want a high specificity. Just to remind your listeners, Julia, the definition of specificity is given negative disease, that is, given no IBI, how frequently do you have negative predictors? And you want that to be high as well, because we don't want to be doing a bunch of tests on people that don't have disease. So the most important factor is sensitivity. And to Paul's point, when you apply the PECARN rule to this third month of age, the sensitivity is equally high, but the specificity, that is, those without disease, the specificity is lower when you apply the PECARN rule. And that would make sense because now Paul and I derived the rule on the patients. So you're going to get a better rule by definition. So to your point, Julia, can you use the PECARN predictors on those? Yeah, you could. And it's still perfectly sensitive, but your specificity will go down, which means you'll be doing more testing and treatment and whatnot than if you use the rule that Paul and I derived in this third month of life.
Okay, let's talk about, we've done this in a data set, a fantastic data set, right? This is a really good data set, but it's not real patients in our typical prospectively derived multi-center studies that PECARN does. How are you using this in your own practice? Paul, you go first.
I think, in the ideal world, these rules really need to be prospectively validated. It's a little bit of a challenge because I think, as Nate pointed out, unlike febrile infants 60 days and below, doing blood testing is not a routine practice in this age group. So you really have to sort of enroll a lot of patients to get an adequate sample size. But that's something we hope and are beginning to work on doing. In the interim, I would say I am in a patient in this age group, 61 to 9 days old, who I'm getting blood testing on, I will apply these cut points, given that it's sort of, at this point, probably the best evidence we have. However, I think I say the caveat too. I think to Nate's point before, I think urinalysis should be obtained on really the vast majority of these infants. Another important limitation of our study is that we weren't able to assess viral testing for the prediction rule. We have a separate paper that showed that the risk of these invasive bacterial infections is very low in respiratory viral positive infants in this age group. So the question is, if a child who clearly has respiratory viral symptoms and a positive viral test, do you need to do more than a urinalysis? And that answer is probably not, though that has to be sort of studied. So I think there's a few caveats to that. But in a child who I'm doing blood testing because I'm worried about them, the clinical appearance, maybe the higher temperature, then I will at this point apply these markers. But the caveat being that I think these obviously need to be externally validated in a prospective study.
Totally agree with Paul. And again, there's the ideal world and the real world. The ideal world is, Paul, you need to get a good big grant and I'll help you and we'll do this prospectively. But the process, it's 10 years. Just realistically, from the time that you come up with the idea to the time that you're podcasting with the famous Julia Magana, it's 10 years. So we got a 10-year gap here to deal with, right? So I will say to your listeners, should be validated prospectively. But if you ask me what I do, I follow the rule. And you know what? The one thing that you raised, Julia, at the very start that I had to smile because I, like we all deal with this. When I see the 2.5-month-old, okay, they come in the ED, they have a temperature of like 38.4. They look good. I'm going to throw a urine bag and dip it. And that's what I'm going to do. But now that kid comes in and they got a temperature of 39.3. I don't know. It just starts to bug me. And you know what? I have to admit, I follow the rule that Paul and I did now because, it's not perfect evidence, but it's the best out there, So I do follow it, both for the temperature side of helping me decide on should I be considering getting labs? And then I always get urine, as Paul discussed. So.
Yeah, I like that. That's a good summary. It's not perfect, but it's the best out there. It's not like a 3.5-star review. No, I think this is fantastic. This is a really good step in the right direction. I think the real big takeaways are that this is better than nothing. And we need more. We need to encourage researchers, investigators like you guys, and funders like HRSA and other big funders out there to say this is really important. We need to do this right. We understand that this is an issue, and the next step is big research. So thank you guys. Keep going. Thanks for what you do, and we'll talk again soon, I'm sure.
Great. And before Paul says bye and I say bye, I'm going to make a plug to your listeners out there. If you care about raising the bar on the quality of how we treat children in this country, please raise your voice and advocate for funding for research in pediatrics and in pediatric emergency care. We cannot lose that because we will not be able to advance care without strong advocacy. And this is an apolitical statement. This is just about raising the bar of care for children in our country. So please raise your voice.
Thanks again for having me. I just want to also acknowledge our co-authors on this paper. So Prashant Mahajan, Bob Grummeyer, and then the EMSC Data Center team, Hong Meeks, Blake Nielsen, Charlie Casper, and Cody Olson. Just want to mention them since they were integral parts of this journey on this project as well. So thanks again for having me.
Well, that's about it for today. Thank you to our department for sending our data to the PECARN registry so we can get these types of answers. Thank you to OM Predictions for predicting hot mics. Until next time, stay curious, stay inspired, and stay tuned.
The opinions shared on EM Pulse are those of our hosts and guests. They don't necessarily reflect the views of UC Davis Emergency Medicine, UC Davis Health, or any of their parent organizations.